Well, the talk is about the management of the toxicities, and first I will talk about cytokine release syndrome, which is seen in up to 85% of the patients with multiple myeloma. It's a systemic acute syndrome that is caused by the activation of T cells. They will activate more immune cells, and then you have massive production of interleukin 6 and 10, and that leads to this syndrome. Important to know is that it can happen more than once in a patient, but it's mostly restricted to step-up dosing and the first cycle of the full dose, and also it's mostly low grade, only grade 1 or 2, and therefore it can be easily managed at the ward. I will talk a bit about the grading of the CRS and also about how to manage it. And the most important tool that we have is to give IL-6 blockade, like Tocilizumab treatment, because that will reverse the symptoms very easily. And you can give that with a grade 2 CRS or if a prolonged CRS grade 1 is present. Thereafter, I will talk a bit about other T-cell directed toxicities like a injection site reaction, but also tumor flare. And that can also happen in multiple myeloma patients. It was not reported in the clinical trials, and it looks a bit like pseudo-progression, so patient experience more pain. And therefore it's important to realize that this can be a tumor flare, and therefore treatment should not be stopped, but instead painkillers and also Dexamethasone should be given. After that, I will talk a bit about the neurotoxicity that is seen. Luckily, it's much less than we see with CAR T-cell treatment. Up to 10% of the patients report a specific syndrome called ICANS. ICANS is also graded using the ASTCT grading score that was developed for CAR T-cells. And it's quite rare, only low grade. And with this toxicity, early use of steroids is of the utmost importance. So don't wait, don't let it stay on for several hours. Give Dexamethasone immediately, and that will reverse the syndrome in most patients, and that's very important. And you won't be affecting efficacy of the drug, so that's also good to know. Then I will talk a bit about infections. Infections are quite common with the use of agents in multiple myeloma, but especially with the use of BCMA-targeting drugs like Talquetamab, like elranatamab, we see much more infections. And they also had a high fatality rate in the clinical trials. Luckily, in the real-world data that were published later on, this fatality rate was much lower, and that's probably because the trials run during the COVID-19 pandemic. But still, infections are very important to prevent as much as possible. So I recommend vaccination before start of therapy, but also to know your patient, know your Hep B, C, HIV status, and also to play a bit with the dosing if infections remain a problem. So skip a dose during an active infection, but prolonged dosing interval can also help a lot. And I will talk about IgG measurements, because most patients have a very low level of IgG, and with some cohort designs, so not real randomized studies, but with cohort designs, it was demonstrated that the administration of sub-Q or IV IgG can really prevent serious infections. So that's also very important to realize. And lastly, I will talk a bit about the toxicities with Talquetamab. That's a drug targeting GPRC5D. And that's not only present on plasma cells, but also on other areas of your body, like your tongue, nails, your skin, and also your salivary glands. And that's why we see toxicity. It's targeted toxicity, but it's side effects that are really difficult to handle. So I advocate to be honest to your patients before that this toxicity will happen, and also to give I give some recommendations how to handle that. And also with this toxicity, prolonging a dose or skipping a dose or lowering the dose prolonging the dosing interval, is a very important tool that we have. And in the end, I will talk about a patient of mine who had diagnosed almost 16 years ago, and he's now on Tocilizumab treatment. And he's running marathons now because he feels so fit. They feel quite normal, and I think that's because there's no use of Dexamethasone on a regular basis after the first episode, and that's really important for the quality of life of our patients.